cartilage than trying to keep the original cartilage which has been dislocated. This is just a short video, again, from a patient which which experienced a patellar dislocation with a really pure chondral fragment. Here you can actually see it in the MRI. There was a delamination of the cartilage fragment in the inferior pole, and doing so, or being in line with this concept in order to try to refixate whatever is possible. Here you actually see the delamination, the softening of the cartilage, slight little step in the cartilage surface. We also performed a refixation of this fragment in an open technique, in combination with an augmentation of the medial patellofemoral ligament using the quadriceps tendon, which is really a nice technique, which is also visible in a VUMEDI video if you are further interested for that. Here you just see the refixation devices. In this case, we indeed used chondro darts in order to have a refixation because it was really a small fragment. But again, we are not afraid of trying to perform these refixations also in pure chondral defects. That was what I wanted to demonstrating that case. So more or less the only indication for not to do a refixation is once you have, for instance, fractured fragments, which just do not allow a refixation from a technical point of view. And in these cases, since the majority of these lesions is actually not really in the weight-bearing zone, but in the majority following patellar dislocations at the very rim of the femoral condyle, for instance, as demonstrated in that case, we also leave these lesions alone because actually bone marrow stimulation already occurred by the injury mechanism. And this is the only situation in which we do not perform a refixation for these fragments. So coming to a conclusion in terms of treatment of acute osteochondral fractures, refixation whenever possible. Also address comorbidities. I did not go in detail with that, but we also perform an early patellar stabilization in the cases which I just demonstrated. We are not afraid of using resorbable implants. These compression screws really provide the benefit of compression, which increases healing chance. And if no refixation is possible and the defect is not located in the major weight-bearing zone, we leave it alone because bone marrow stimulation has already occurred. Refixation is also something which we are not afraid of in chronic lesions. And I now come to the chronic osteochondral defects. Here you see a young patient, 17 years old, with a typical osteochondritis dissecans, actually a stage 2. You see some sclerosis of the bony fragment, but in the arthroscopic sequence, you don't see any severe affection of the superlying cartilage. And in these cases, if there's any instability of the fragment, we quitted to do only a drilling, which we performed for a long time, but we also recommend to do an additional refixation in these cases. Here you actually see a very comparable case in which the patient was affected on both sides. And here you see the 6 months following MRI. You also see the biocompression resorbable screw in the center of these lesions. And you actually see, especially in the sagittal view here, that a nice healing of these fragments occurred over time, and we do an enterocrat refixation in these specific cases. Here you see the arthroscopic views of those surgeries. The diameter of this screw looks really big arthroscopically, but it's 0.0 millimeters, so it's really okay to have this refixation performed also from the cartilage side, even if the cartilage was not affected, and we observed much better results compared to retrograde drilling alone if there is an instability of the fragment. And again, there are studies which are really comparable to the study I showed previously dealing with acute fractures. Even if in these chronic cases, a degeneration of the osteochondral fragment is observed and you perform a refixation, this is also reversible. So over time, we became more and more generously in order to perform refixation of these osteochondral fragments, even if there was an instability and even if the clinical course of this patient was longer than 6 months or 12 months. This does not mean actually that everybody of these osteochondral lesions needs a surgery. And I included this case here, which is a typical indication, in my personal opinion, for conservative treatment. Again, a 17-year-old young patient, typical location for an early stage of osteochondritis dissecans. Actually, grade 1, we do not see any sclerotic bone. We see an intact cartilage in the MRI. And this is definitely a patient, in my personal opinion, who has a really good chance for conservative treatment. How can we estimate the chance for non-surgical treatment in these early osteochondral lesions? How we do that is actually that we refer to a study which has been published by Krause from Hamburg in Germany in 2013 in the American Journal of Sports Medicine. And what they were able to show is actually a score which is correlated with the chance of healing under non-surgical treatment. This is really interesting. They identified several risk factors for failure of non-surgical treatment, and based upon this risk factors, you can actually estimate the chance for healing after non-surgical treatment. And the major risk factor is subchondral sclerosis, subchondral cyst, and really large osteochondral defects. What is really remarkable in this study is that they observed a really poor healing rate in the first 6 months. So you should definitely do not recommend an early MRI after 2 or 3 months, because this is actually, or you very likely observe a non-healing at this early time point. And this study actually underlines that you should wait until 1 year before you make your final judgment about if healing occurred or not. What does non-surgical treatment mean in our clinic? There's actually no specific standard, but every non-surgical treatment, even in children, should contain partial weight bearing for at least 6 weeks. We usually allow 15 kilograms of weight bearing during that time. No sports activity for 6 months. And since vitamin D is really an important factor in this osteochondral lesions, we regularly recommend concomitant vitamin D substitution. This is a patient who does not qualify for non-surgical treatment because, according to this score I just introduced, he fails to have a good prognosis for non-surgical treatment. As you can see in the left MRI, actually there is subchondral bone loss, subchondral cyst, sclerotic bone, and an overlying cartilage defect. And once you scope this patient, you actually see this instability. But again, since there is no osteochondral fragment, this patient also does not really qualify for a refixation. And this is when other kind of therapies come into play, such as osteochondral transfer or even subchondral bone augmentation in combination with cell transplantation. Here, another patient in which we just performed an osteochondral transfer a couple of weeks ago. Osteochondral transfer was really popular in Germany and Europe during the late 90s, and it really became less popular during recent years. And one of my personal explanations why it became less popular is actually the problem of harvesting the osteochondral plaque. So it was really popular to harvest this from the patellofemoral joint in earlier days. But in my personal opinion, this is not really a good location for harvesting, because there is no non-weight-bearing zone in the patellar groove. And as you can see here in this MRI of a patient who was just referred to my hospital a couple of weeks ago, and this is the scope, the harvesting site is really a problem if the patella touches this harvesting site, as you can see it here in this arthroscopic sequence, but as you also can see in this MRI. And this is actually why we are not using this patellofemoral joint for harvesting for osteochondral plaques. And I'm personally really recommend to use an alternative harvesting site. And we have introduced to use the posterior medial lateral condyle for about approximately 10 years now, and we are much more satisfied with this approach. This is actually a short video sequence from today, actually. The patient is placed in prone position, and this is probably the disadvantage of this technique, because you have to turn the patient during the surgery. You have a little incision over the posterior aspects of the posterior condyle. We are using a specific instrument, which is called a diamond twin instrument by the company Storz. And through this incision, we take this osteochondral cylinder from the posterior aspects of the femoral condyle. And in the second step of the surgery, we apply the osteochondral cylinder in the defect area in supine position immediately after we turned the patient. An additional benefit of this instrument is that it is available up to a diameter of 20 millimeters, which really makes this technique eligible for even larger defects by using only one plug. And this is definitely something we learned for osteochondral transfer. The best outcome is achieved once you're using one plug only. And since the majority of the instruments is limited by the size, typical defect size is 9 or 10 millimeters in diameter, this instrument actually allows you also to treat larger defects. An alternative treatment, which we are also using by using these diamond twins, is the combination of subchondral bone augmentation and autologous chondrocyte transplantation. And this is demonstrated in this video here. So again, the subchondral bone in this OCD of the medial femoral condyle is debrided by using this diamond twin systems, but we are not transferring an osteochondral plaque in this case, but we go to the anteromedial tibia and take a bone graft which contains of cortical bone, but also subchondral cancellous bone. The periosteum is actually removed, and we only use this bone plug in order to perform the reconstruction of the subchondral bone. Therefore, the bone plug is placed in line with the subchondral bone, and on top we use an autologous cell transplantation technique. This product is called Novocard 3D. It's provided by a German company. 4 weeks prior to the surgery, cartilage is harvested and sent to the laboratory. Expanded cells are applied on this membrane. And on top of this subchondral bone augmentation, this cell product is applied, and afterwards the defect is sealed with fibrin glue, as you saw in this video sequence. This is actually our technique in a larger cartilage defect. So you definitely have some lesions which exceed a diameter of 20 millimeter. So they are not eligible anymore for this diamond twin system. And in these cases, we actually combine a subchondral bone augmentation using traditional cancellous bone graft, for instance, from the iliac crest, but also from the tibia. and combine this with a cell transplantation in order to have a regeneration of the cartilage at the same time of the bone augmentation. And this works really nice, specifically in younger patients. You can see here, there are still open growth plates. So this patient is actually 13 years old, large osteochondral defect. And as you can see here, almost a perfect healing 1 year following the surgery. And here another MRI, you still see the harvesting of the subchondral bone from the tibia, but the healing in the medial femoral condyle really looks nice in the T2 sequence, but still in the T1 row, you see some slightly different signal of the subchondral bone, which dissolves actually over time. So coming to a conclusion, today I was really focusing on the surgical aspects of treatment of these osteochondral lesions. Nevertheless, non-surgical treatment is definitely something which is appropriate for these grade 1 and 2 lesions. I'm really a fan of this Krauser score in order to estimate the chance for a healing once you observe an osteochondral defect, but stability is really an important parameter. And once you have MRI signs such as subchondral bone sclerosis, subchondral bone cysts, which are correlated with an instability, this patient probably more or less requires for surgical treatment. But independent from the acuteness, do think and do consider refixation. We are really, really generously, I repeated that for a couple of times now, with refixation of these unstable fragments. And all these other techniques, which I demonstrated, osteochondral transfer, combination of cell transplantation with subchondral bone augmentation, are actually only required if refixation is not an option. And our indication for the osteochondral transfer is actually when we can deal with one cylinder only, which is really favorable in terms of clinical outcome at the end. I want to make two more specific points at the end. This is something which I personally consider really interesting. It's a theory which has been introduced by Carlo Camatias. He's from Switzerland, from Basel, and it's the so-called doorstep concept. So we are always wondering about the reason for an osteochondral lesion in specifically in pediatric patient. And what he thinks is that actually an instability of the meniscus, especially of the lateral meniscus, might contribute to the occurrence of an osteochondral lesion, such as osteochondritis dissecans. And this is a really interesting theory. He calls it doorstop phenomenon because actually there's an impingement of this unstable anterior horn of the meniscus and the femoral condyle in extension, as demonstrated in the video sequence on the left. And what this group introduced is actually the concept of performing a refixation of the meniscus in terms of a treatment of the cartilage defect. And this is a patient in which I also performed that. Here you see a patient with an osteochondral lesion. You see on the lateral femoral condyle that we did some refixation in addition to this treatment of the meniscus. But you really see an instability of the anterior horn of the meniscus, which leads to this potential impingement in extension. And you easily can apply an outside-in suture in order to provide more stability of the anterior horn of the meniscus. I'm not personally convinced 100% that this really explains the osteochondral lesion, but since the intervention in terms of these outside-in sutures is really a small additional surgery, we are really generous in order to additionally apply this. And there is already some scientific evidence for that. Interestingly, this group, again, the group of Carlo Camatias from Switzerland, And they designed a really nice study because they compared sutures only. So they did really not address the osteochondral lesions and compared that with screw refixation of these osteochondral lesions. And they observed comparable healing rates, which is really remarkable and really an indicator that maybe this instability of the meniscus contributes to this osteochondral lesions. So I just want to keep this or want you to keep this in mind once you observe these osteochondral lesions and once you scope the patients. Always have a look at the meniscus, and maybe from time to time you feel that there is a instability and you might want to add an outside-in suture. And the last aspect I want to point out is that you always should consider alignment in these osteochondral lesions, especially in younger patients, because, for instance, using aid plates or any other implant for temporary epiphysiodesis, you are really able to have a limited risk for additional realignment in these patients. And we know that osteochondral lesions are correlated with malalignment. So also always have an alignment check in these patients. That is true for pediatric patients, but also osteotomies should definitely be considered an concomitant surgery. And once we do these complex treatments for these osteochondral lesions, as I demonstrated earlier, especially when we are using cell transplantation in order to have regeneration of the cartilage, we are really strict with alignment, and even if there's only 4 or 5 degrees of malalignment, we go for concomitant surgery. So don't forget about the concomitant pathologies. This was actually what I wanted to share with you. I'm open to your questions, and thank you for your attention.
Thank you, Professor Niemeyer, for this nice presentation. Actually, we're happy to have to hear that your experience cover all aspects of possible treatment for chondral lesion and osteochondral fractures as well. Actually, I will start my question and then I will ask the colleagues if they have. It seems to be that there is like few questions for you. My question was that fixation of chondral lesion, whether acute or chronic, you didn't mention anything about combination of bone marrow transplantation, bone marrow stimulation and fixation, especially in the OCD or in the just simple chondral lesion. Is there like any rule for simultaneous bone marrow stimulation and fixation?
Yeah, so actually I wanted to mention because that's mandatory. So once we have any sclerotic bone, we need to have any perforation additionally, and be really aggressive in order to try to remove or at least perforate the sclerosis. That's really important aspect. And once we do this chondral refixation that I demonstrated in this one case in the lateral femoral condyle, we always do in subchondral bone marrow stimulation in addition to this refixation. There's no really scientific proof that it's necessary, but in my personal opinion, it just makes sense in order to get a better biology.
Okay, and regarding the chondral lesion, so you showed us like few cases of chondral lesion fixation. I'm not sure, sometimes we face that it is friable, like the chondral lesion is friable in one way that you cannot fix it, or if you try to fix it, it will like fragment in one way or other.
Yeah, so the limitation for refixation is definitely a technical one. So once it breaks during refixation, you should have any backup strategy, definitely. But I just wanted to point out that I'm not convinced that chondral fragments do not heal. So this is something I learned during my education, actually 10 or 15 or 20 years ago. But I'm absolutely convinced, and there's also some studies on that pure chondral lesions can also heal. So once you really have large lesions, try to refix it in combination with subchondral bone marrow stimulation. There is definitely a chance. That is what I just wanted to point out.
Third question, asymptomatic OCD, asymptomatic osteochondral dissecans. Nothing to be done, even if it is an incidental finding during surgery for other reason, like meniscal repair.
This is a really difficult question. So once I see an asymptomatic OCD, for instance, in a patient who had a knee distortion and who was not symptomatic until that point, I do recommend a surgery if there's a good, if there are signs of instability in the MRI and there's a good chance for refixation, because I don't want to miss the chance for the refixation. Yeah, but if there's any bone loss and there's no chance for refixation, I personally do not consider it a risk factor for consecutive osteoarthritis. So I would definitely observe it. And I would not really recommend any more complex type of therapy, such as ACI or osteochondral defect, if there's no symptoms. But the chance for refixation is only available or eligible in early stages. So I might consider it in this specific situation.
Okay, thank you. So start with Dr. Yazan Hattar. Dr. Yazan, please ask your question. Just wrote a question in the chat.
Thank you so much. My question is about the size of the for the refixation. How much do you think is possible to refix? What is the minimum size for refixation?
Yeah, this is also a technical limitation. So once you use a screw with a diameter of 2 millimeters, there's definitely a limit of approximately 6 or 7 millimeters in diameter. In these really small lesions, you can also use these control darts. They may allow maybe also to refixate maybe a fragment with a diameter of 5 millimeters, but probably due to technical limitations, smaller defects are not eligible for refixation, my personal opinion. But interestingly, the majority of the fragments is probably somewhere between 1 and 2.5 centimeters in diameter. So it's really comfortable to place a screw in.
Okay, it's okay for you, Dr. Yazan and Dr. Iyas Sgaili.
Yes, Dr. Khaldoun, thank you. And thank you, Professor Philip, for this nice presentation. My question about the osteochondral fixation, the point that you said about if it's not eligible for fixation, leave it alone regarding the patella. I want to ask about your experience. What is the natural history, or what is the fate of leave it alone technique for the patellofemoral joint?
So actually, when I was saying that, I was actually referring to the fact that once you have an osteochondral fracture, actually at that time bone marrow stimulation occurs because the subchondral bone is opened. And we observe quite a good healing of these defects. Additionally, these defects are, in the majority of the cases, not really located in the major weight-bearing zone, but really at the edge of the medial aspects of the medial patellar facet. And in these cases, I just wanted to point out that I do not consider it necessary to perform any complex cartilage repair surgeries at the index surgery. So there is quite a good chance of healing spontaneously since the subchondral bone is stimulated, and there's no benefit of an early cartilage treatment. If it doesn't work, you can still do that in the chronic situation.
Okay, thank you. Dr. Muayyad Abu Qaoud.
Yes, thank you for the great presentation. I think you answered the first question. I'm going to go to the second one. My question is about the fresh osteocartilaginous grafts. What do you think about those grafts? I know there are like some articles talking about good results after long years, like good duration for this kind of allograft. So what's your opinion regarding those?
I do not have any personal experience because all fresh frozen osteocartilaginous allografts are not available in Germany due to regulatory issues. I really follow international talks closely, and I would really love to use them because I believe that it's a really interesting treatment option. There's some guys in Europe who really promote that. One of them is Pablo Gelber from Barcelona, for instance. He always recommends a limit of 6 millimeters, which means that he's really critical in larger defects with a bony defect of more than 6 millimeters because of the viability of these grafts. But this is, again, just an opinion I can tell you about because I don't have any experience, but I personally would really like to use it because I believe that osteochondral grafts in general is a good option. Harvesting is a real problem, and you don't have any harvesting issues in allografts.
Yeah. Okay, thanks.
Okay, thank you. Dr. Muthanna Al-Yamani, please. Dr. Muthanna?
Yes, hello. Thank you, Prof. Niemeyer, for this very nice presentation. I actually have two questions. You mentioned about addressing the instability after you have an osteochondral fracture of the patella following an episode of dislocation. Would you go for reconstruction at that time when you first, in the first instance, when you fix your osteochondral piece, or would you just repair?
Yeah, so we actually do this simultaneously in almost all cases. I'm absolutely aware about the potential problem of complex reconstructions in acute injured knees. I'm absolutely aware of that. But for the refixation of the osteochondral fragment of the patella, usually an arthrotomy is necessary. And in my personal opinion, there's no that much additional harm for the knee when going for a concomitant stabilization. But there's also patients who require more complex approaches for stabilization of the patella, such as trochleoplasty or even osteotomies. And in these cases, we actually do this in a second step because I don't want to have, for instance, a trochleoplasty in an acute injured knee. But MPFL reconstruction goes along simultaneously in our hospital with refixation of the fragment.
Yes, thank you. Can I ask a second question, please?
Yeah, please.
Yes, thank you. Here we have issues with secondary gain and compensation following, osteochondral defect treatment. I don't know if it's the same case in Germany. So we have an issue with following these patients up, and the first is with the diagnosis, whether this actually was an incidental finding on the time of presentation and they're coming to your clinic with a chondral defect, for example, that is not causing the pain. So what would be really helpful in diagnosing these cases and then the follow-up of these patients. I don't know, we sometimes revert to bone isotope scan sometimes for these cases. We're thinking of adopting a PET-CT scan, because these are a big issue for us. We have, not only in the knee, but in the ankle, for example, also, when we're following these patients up. I don't know what's your thoughts about that.
Yeah, I'm not sure if I got your question properly, but we are usually following up these patients by MRI. I personally consider SPECT-CT a really nice option for that. I didn't include that in my presentation, but PET-CT is definitely really sophisticated and also in Germany not available really frequently. But SPECT-CT is quite becoming popular. And in my personal opinion, SPECT-CT provides you really good information about viability of the fragments. And we also use that preoperatively in order to judge about the potential chance for healing after refixation. So I'm personally a fan of SPECT-CT. But also you were talking about compensation. We are also in the German health system, follow-up patients is quite critical, but nevertheless, MRI is actually not a problem, and we perform it at 6 and 12 months following surgeries, but also non-surgical treatment.
Thank you very much.
Okay, thank you. Next question for Dr. Mahmoud Al-Muhtasib. I can ask the question if Dr. Mahmoud is not like, what's the role of vitamin D and what is the dose for using, because you mentioned it as a non-surgical one of the option actually.
So we apply vitamin D in every patient with a chondral defect, with an osteochondral defect, and also in every patient with a subchondral bone marrow edema. Interestingly, the guy from Hamburg, Herr Krause, which I cited earlier, because he introduced the scoring system, also published a really nice histological paper. And based upon that paper, vitamin D or an deficiency of vitamin D might also play a role in the occurrence of osteochondral defects. And this is an approach which is kind of new. But since vitamin D or vitamin D substitution is that easy, that cheap, and without any risk, we are really generously in applying that. We do approximately 2,000 units per day, and we don't really rely on any laboratory. We don't really measure the vitamin D. We're just giving that for a period of 3 months at a minimum, and we are really generous with that.
Okay, thank you. Actually, in Jordan, we have problem with vitamin D. So it's almost just need to have vitamin D measurement as part of our routine lab, because it was like years ago where they found that a lot of people in Jordan, they have vitamin D deficiency. And we published actually, and a lot of publication from Jordan measured like vitamin D and association with different diseases, not only orthopedic, but also other system diseases. So we are familiar with using vitamin D, and we're measuring vitamin D actually in a lot of cases. Thank you, Dr. Professor Nimer. I have just a question for just reminding the colleagues about using synthetic graft in osteochondral lesions. You know that there were like products from different companies to use like cylinders, synthetic cylinders to compensate the defect in the bone and cartilage. Do you have any experience? Because this is good always to revisit the usage of such a synthetic product, like the previous usage of the synthetic ACL graft. And we published actually newly a paper about revisiting synthetic ACL graft to find out that there were a lot of long-term complication after using these synthetic ACL grafts. Please, if you have any experience, just to mention for us.
Please unmute yourself, Nimer. Please
Professor,
unmute yourself.
Professor Nimer, can you unmute yourself, please?
I'm sorry for that. So to be honest, all these artificial implants actually, to be honest, somehow failed our expectations. We have been part in a clinical controlled randomized trial a couple of years ago, evaluating the clinical outcome following from a product from Italy, which was really promising due to all aspects we know from preclinical experiments. But also in these cases, we really did not observe satisfying results. So at present, I personally definitely go for biological or for more biological solutions. There have some biomaterials which even have been taken from the market in Germany within the last 10 years because it was somehow disappointing.
Thank you for your answering. Any question from the audience? Okay, then Dr. Professor Nimer, thank you for your time and presentation. I would like Dr. Faras, you can like end up.
Thank you very much, Professor Nimer. Thank you very much, Professor Khaldoon, for this coordination and this moderation. Very nice talk and up-to-date topic. Thank all colleagues for being with us, and big thanks for Dr. Ashraf Jbarat, because he's the one behind the arrangement and the invitation to our guest speaker today. Thank you all. Thank you all. Enjoy this topic, and in the future we'll hope to have another collaboration concerning injuries around the knee.
Thank you
Thank
also from my side. It was really a pleasure to join you and great discussion, great questions, and hope to see you all in person at some time.
Thank you. Bye.
Thank you.
Thank you.
Navin.
Thank you خلدون. شكرا.
Thank you.
الله يعطيك العافية.